I think we should begin now. Once again, good afternoon to all. Welcome to the Telearogya series on OSCE and related training. Today, we are requested for some volunteers. So I still need two volunteers. If you could just add up your email ID on chat, our technical team, Mr. Sriram, will actually assist you to become a panelist. You have to re-log in using the email ID and you could actually interact with the examiner today. And today we have a special guest, Dr. Nandini Chakraborty today. If you understand how we were able to get Dr. Nandini, it's really a surprising thing. I put up a request asking people to help me out conduct these classes, and Dr. Nandini volunteered, and she readily agreed to take a class for postgraduates in psychiatry. She's very familiar with OSCE system of examination evaluation. She works as a consultant psychiatrist at Leicester and NHS Trust. She's also an associate dean for Equivalence, Royal College of Psychiatry, and she's also a honorary associate professor in the University of Leicester. She's actually had a wide experience in evaluating students on OSCE format. And today she's going to have a very different form of evaluation. She's trying to see how a simulated patient can be, trying to understand the difficulties in actually evaluating a person who's not actually a patient. It could be a lot more easier sometimes. Sometimes it can be more tougher if you have a student who's actually trained in psychiatry or a psychiatrist himself being an examiner in the current scenario. So Dr. Nandini will simulate few scenarios for all of you. And the volunteers are requested to evaluate this case scenario. The volunteers will have a chance to evaluate the process based on the case that's been displayed. And this process of learning is almost like a workshop model where we actually learn a lot from actually doing it. We have to be prepared for exam, and actually simulating this sort of scenarios is the best way to learn. Over to Dr. Nandini for you to anchor this show for the next 1 hour plus. Thank you so much for agreeing to be a part of our faculty.
Thank you very much for that kind introduction, Dr. Mahesh. It's a real pleasure to be doing this from UK. And perhaps the entire COVID scenario has not been all that negative, because I think we are virtually a lot more connected. And I don't think I would have been taking this class if it was not for COVID, paradoxically. So I will start with my slides first. Everybody can see my first slide? Yeah? Okay. Yes. Yeah. Okay. So good morning from the UK. Good afternoon in India. And I understand that students who are due to sit DNB exams next month have had a very close notice of a complete change in the exam system. Now, simulated cases are something that I've been very used to in UK right from giving the PLAB exam. And the PLAB was a very different experience, and we had to completely change our outlook and the way we approached cases and exam, but we learned from there. Now, it's the most objective form of exam you can have. With long cases, yes, it's as natural as can be, but you are left with a greater element of luck in terms of what kind of patient you get, and the experience can be very different for all examinees. So simulated cases are a similar experience for all examinees. It's fair, it's objective. The way I see it is that we do compromise the validity perhaps, but the reliability, the comparability across all examination centers will definitely be better. So what happens over here? In a 15-minute scenario, you are not going to do everything that you did with a long case. With a long case, you weren't given a specific question. This was your patient. You do everything that you do on a day-to-day basis from top to bottom. You take a history, you do an examination, you formulate a management plan, diagnosis in your head, which you're going to explicitly talk over with your examiner. And your examiner can ask you any sort of question. That doesn't have to be standardized. They can draw it to their area of interest. So you've got to be prepared for everything. Whereas in a simulated scenario, for a 15-minute session, it's going to be focused. And what you've got to practice first is to keep to the focus. If it's history taking, you do a history taking. If it's a mental state, then you go into mental state. Don't take the parts of history taking which are not exactly a part of mental state. Risk assessment, focus on the risk first, do the peripheries later. Discussing management with patients, this is probably the easiest because you're given all the information and it is for you to give information to the patient rather than elicit information from the other end. But you have got to prevent the temptation to lecture at the patient. There is a technique over there where you give the information in bite-sized chunks. You check with the patient how much they are understanding. You check with the patient how much they already know, whether they have any preconceived notions. So you do it in a way that you would want your doctor to do it with you. I think one way of thinking how you approach any scenario is behave with a patient the way you would want a doctor to behave with you or a family member. And then there are communication stations, something that a long case did not directly deal with. Depending on the sophistication of an OSCE, you can be given a station which doesn't test your knowledge about psychiatry to that extent, but it's more about tackling a difficult communication, tackling an angry relative, discussing a difficult diagnosis with a patient, trying to do it as gently as possible. The mark scheme depends on the examination board, so we don't know what they are doing over there. In terms of where it's examination, history taking, as far as psychiatry is concerned, communication will always have a certain block of marks. But depending on the station, there might be more marks on the knowledge content, less on the communication. Whereas if it's a communication station, the marks might be 50-50. So who's involved? There's the simulated patient. Now, just to give you a little bit of background about where things develop, for example, in the UK, where simulated stations, OSCEs are the norm of the day, whether it's psychiatry exams, whether it's GP exams, whether it's medical school exams. So there are entire actor companies who make a living out of it. Even if you're not a great actor, as long as you've done some kind of drama classes, even if you don't hit it big on the stage or screen, you can be assured of a living because simulated patients are used so widely in training and exams throughout. It might take a bit more of time for that to develop in India, but it looks like DMB is making the start. And if somebody has conceived this idea of the new exam, that someone possibly knows how OSCEs are run in different countries and they know what they're doing. But going through the DNB webinar slides, they have said that this person could possibly be a volunteer. They've not said it will be a professional actor. So a volunteer, I am expecting, will be a doctor or a medical student, possibly. But they should be given a specific brief. So usually for these scenarios, to keep them standardized, the actors do not go in blind. They just don't go in passively and sit there for you to talk to them or give them lectures. They are given a very specific brief about what questions to ask, how to behave. If the examinee does this, then you do this in return. For example, angry relative. Let's say when the scenario starts, the person is standing in the middle of the room with their arms across their chest and will not sit down. Examinee comes in and they say, hello, I understand that you're displeased about something. Can we have a chat about it? Well, this person is still very angry. Then they say, there's a chair. Could you please have a seat perhaps? And then we could have a chat. And the angry relative says, no, I'm not going to sit down. I'll keep standing. The brief might say that if the examinee continues to say the right things, I understand that you're distressed. I understand that there are things that you want to talk about that you're not pleased about. Give us a chance to talk through this. I'm sure we'll come to a resolution. If they are nice to you, then you take a chair. Sometimes I've gone into these scenarios as an examiner, and the worst thing an examinee can do is, please take a chair. Oh, you don't want to sit? That's fine. I'll sit down. And the examiner, and it looks really odd. You know, the person is still standing in the middle of the room, and the examinee plonks down into the chair. So there is a flow to it, but usually to maintain the standardization, there are background briefs being written along with the questions. The examinee will interact with the simulated patient as per task. So whether it's history taking, examination, explaining a treatment, management plan, the examiner is holding a very different role over here. So the examiner might be observing in a corner of the room, or nowadays it might be a camera. And whether they interact with the examinee or not depends on their brief again. Again, examination in the UK, usually I have seen very, very little examiner interaction, whether it's the membership exams, FRCPsych exams, and in the PLAB, there is very brief interaction, sometimes at the end, perhaps, can you tell me your differential diagnosis? FRCPsych, the Royal College of Psychiatry exams have no interaction at all. A good examiner should be neutral but warm, show no expression at all. We've had complaints come in from examinees where examiner has apparently raised eyebrows or smirked or shown some kind of expression. I don't think it'll go that far in exam set in India, but if DNB is training their examiners in the new format, I'm not sure whether it's happening, it should. A good examiner in an OSCE should be completely neutral. So if that has been their brief, don't go into a cubicle expecting an examiner to smile and nod and show that you've done a great job. Usually we are very used to knowing by the time we've walked out of the examination hall whether we are going to pass or fail. We have a fair idea about it. In an OSCE, you should not have a clue. Right. So general points, cover the basics, introduce yourself, ask for the patient's name. The scenario will not give the patient's name. It will say 20-year-old woman or 25-year-old man. You ask for the patient's name, ask them how they want to be addressed, explain what you're going to do, ask for consent. It doesn't have to be, obvious consent if you're interviewing a patient, but just asking, is it okay? I'm going to ask you a few questions. I understand that you're distressed. It's a difficult time to talk, but we can help you only if we talk openly and honestly. So is it okay to go ahead along those lines? Setting common ground with the patient. Being structured in approach. Neat, focus, obvious in what you're doing, especially if you're going to have no interaction with the examiner. So if you're not going to have a chance to present a structured mental state examination, this is what I observed, this is what I elicited, these were the symptoms, etc. It's an art of just talking to the patient, but almost telling your examiner, this is what I'm doing. And covering the main points first. Sometimes we do have the temptation of going in and eliciting or saying something weird and wonderful, something that we've read in the footnote of a reference book somewhere, thinking that's going to be greatly impressive for your examiner. Remember, your examiners are human. They probably know less than you do on the exam day because you're a lot more prepared in theory. So the weird and wonderful is not going to cut it with them. Keep it simple, keep it basic, make sure that you don't cover the main points. So you ask about something really, very, very rare, and then you miss a really common point because you've run out of time, that's not going to help. Keep note of the time and use at least 1 minute to summarize. Today, I've asked for an alert at 1 minute, that we know where that 1 minute is. In the exam hall, try and keep an eye on whether you're going to be told just at the end of 15 minutes or whether they are going to give you a warning bell with 1 minute time. If not, keep your own watch. That last 1 minute is really important to tidy up, to go through the points that you know are absolutely major and you have to cover in order to pass. The beginning and the end. Use the 1 minute in the beginning to read the task carefully and decide how you're going to approach this. This is so important, but in the midst of an exam anxiety, we read half the scenario, our minds going at 1,000 miles per hour, and we read half of it, we perceive half of it, and we go in a completely different direction. It's very possible. I've seen people make mistakes, like even if the name of the patient is given in the scenario, they have missed the name of the patient, or worse still, the scenario is not about the patient, it's about a relative, and they've missed that completely, and they come in with the notion that they're talking to the patient rather than the relative. And in the middle of it, they realize who they're talking to, and that creates a complete mess. So be calm, take a minute in the beginning to read the task and decide. The last minute to summarize. One of my biggest realizations, reflections when I did my first examining at the Royal College of Psychiatrists is that examiners do not have an indefinite attention span. You've been sitting at the same station, watching 16 candidates throughout the day, come in, ask the same questions, elicit the same history, use the same cliche phrases, show the same kind of empathy because they've all gone to the same practice session. And at the end of it, you're more relieved that the exam is over than the examinees are. And then what starts to happen towards the end, I'll be honest with you, is the examinees start merging into each other. Unless an examiner is really focusing, you then start missing that point. Was it this examinee who said it, or was it the previous one? Did the examiner ask this, or did they miss it? So when you summarize it at the end, the examiner is relieved. Okay, fine. Yes, she did ask this, or he did do this. So you want to give them that summary at the end. That's very important. And try to remain fresh, impressive, make the examiner wake up. You know, your simulated station, I noticed in the DNB slides, is going to be post-lunch. Not a good time for people's attention spans. Keep that human element in mind. So with that, we have case scenario 1. A 25-year-old woman has been brought to your clinic by her parents. This morning, she has made cuts to her wrists. The injuries did not need any stitches. Her wrists are bandaged. She is medically stable. Her parents are worried that she might do this again. You are speaking to her in confidence. Do a risk assessment. Formulate a management plan with the patient. So I'm going to stop sharing my slides at the moment. And Dr. Vasundhara, I believe, is going to interview me, which is really, really brave. So welcome to Dr. Vasundhara. And you know, if we were in a hall, I'd give her a clap because it's very brave. We have 10 minutes. And I'm going to go into role Vasundhara. So for the next 10 minutes, I am no longer Dr. Nandini Chakraborty. I am this 20-year-old patient who is sitting slumped in a chair in front of you.
Um, Good afternoon. I'm Dr. Vasundhara. I'm one of the trainee psychiatrists over here. And I'm here to sort of speak with you about some things that have been concerning your parents. I understand some of these things may be difficult for you to express, but we can go in the pace that you feel that you're comfortable with. And would it be okay
I don't think
if I
you
asked
can
you?
help me. I don't think you can help me. I'm in a very difficult situation. I know my parents are worried, but I had no choice.
So I understand some of these things are very difficult, Miss, and I understand that they can feel
You don't have any understanding of how difficult it is for me.
Well, would it be okay to talk about some of the things that would be difficult?
If you wish.
I'd want you to feel comfortable talking to me about some things. You should know that anything you say to me here is going to be between you and me, apart from the fact that when I do feel that you may be a harm to yourself and it may be life-threatening, then I may have to break these rules. Apart from that, I think we can keep things in confidence between you and me. Would that be all right?
Okay.
Can you tell me what events happened today?
My parents don't know. I had a in the last 6 months, and yesterday he told me that he was breaking up with me and he was marrying somebody else. And he put it up on Facebook, and all my friends know that I've been dumped, and I can't even tell my parents because they'd be so disappointed in me. They didn't even know I had a boyfriend. What am I supposed to do? Somebody will tell them, it'll come to their. I'm just in a mess.
I'm sorry, I understand that this must be very distressing for you. Having to go through a breakup can be really stressful for people. Can I ask you some more questions about what happened or what led to this breakup?
He suddenly said that his parents had found somebody else for him, and he couldn't tell them about our affair. Our families were too different, so he just took the easy way out and said that he was going to marry who his parents for him. So he was cutting off.
I understand. How did that make you feel?
How do you expect that will make me feel? After 6 months of going around with me, if somebody dumps me and then puts it on Facebook and I can't even discuss it with my parents, how do you think it's going to be?
Okay, I understand. Is that what I understand that I've been told that you attempted to harm yourself. You sort of cut your wrists.
I wanted to kill myself. I wanted to kill myself. Making cuts is not that easy. My mother just came into the room when I wasn't expecting her to, before I could make a deep cut. I even have a suicide note written in my room. Found it as yet. I'm serious. And nothing that you say is going to make a difference. You can't lock me up over here. I'm going to go home and do it again. If cutting my wrist isn't an option, I'll find another option.
Miss, I understand that these situations are very difficult and you feel like you have no way out. Can you tell me how long you've been thinking about these things about harming yourself?
Just yesterday, he told me, and I took an immediate decision.
Okay. And before committing or doing this, did you talk to somebody? Did you try to call somebody for help?
No, I just don't want to face anybody. I don't want to face my parents. I don't want to face my friends. I just want to end it all. It's just too difficult and too shameful to deal with this. And I hope he can, I hope he will be punished. Maybe he sees that I've killed myself. It will bring some remorse.
So, from what I understand, this was something you did as in the spur of the moment, yes. So, can you?
I don't know whether you call it spur of the moment, but I was serious. And if my mother hadn't come into the room at that point of the time, I would have done it good and proper. They would have come in, found my dead body with a suicide if they had searched my room properly.
Can you tell me, at the point, what means did you use to actually harm yourself?
I used my razor.
Okay. And you said you wanted to end your life. So when you had, can you tell me? Right. After you did sort of cut your wrist, can you tell me how you felt right after that?
I was in the middle of it. I was just starting to make some light cuts, and I would have made a deeper cut and ended it all.
Right. When you said your mother came in, can you tell me what happened after that?
She started screaming. She started screaming and called for my dad. My dad came back. He was sitting there in the room, just off her head. Then my sister came in and helped bind my wrists.
Okay, I understand.
Dr. Nandini and Dr. Vasundhara, there seems to be a background noise. I'm not sure where it's coming from.
So there's a patient right next door who is a little agitated. I'm sorry.
I think it's
could
coming.
Move, sir.
If you could move to a little silent room, it'll add to the clarity of the discussion.
Yes, I can move to Dr. Pepe's room. Just give me a minute. I'm really sorry.
Dr. Vasundhara is in the hospital. I think there's a lot of noise, so she has to find quite a place.
Is this better, sir?
This is better.
Thank you, sir. I'm sorry for the interruption.
Go ahead and continue, please.
What do you want to know?
We were talking about when you were telling me about the fact that your sister came in and that she helped you bandage. What happened after that?
That they brought me to this clinic and you're talking to me. That's it.
When you look back at what happened, how do you feel about it now?
I told you, I'm just going to go back and do it again. I can't face anybody with this.
I understand. These events can be very distressing for a person, and you may feel like you have lost a lot. And I understand what could be possibly going through. Can you tell me if there's any way that I can help you, or any person or anything else that could maybe act in a positive way in this situation, and you could probably look at it as something that would protect you from harming yourself?
I suppose my My elder sister might be able to help. She's
Okay.
and she lives a little far away, but perhaps she'll understand a bit better.
Okay, I understand. Have you been in touch with your elder sister lately?
Mm.
Okay. Who in the family do you speak with and share your feelings with the most? Your elder sister? Okay, I understand. You said
She's the only one who knew about my boyfriend.
okay. And does she know or also is aware of the recent events that have taken place?
Things happen too quickly.
We are 9 minutes down.
Okay. You also mentioned that you would try to do this again when you go back home. Can you tell me what means you could possibly think of?
I don't think I'm going to share that with anybody.
I understand. Would you like me to help you with this?
I can't be bothered. People seem to have taken the control of my life out of my hand anyway. So what I say, what I think, what does it matter?
This could be a rather stressful situation for you, miss, but help is available and help can be given. And there are chances that you would feel differently about this if you allow me to help you.
Do you
Time
think
up.
so? Okay, out of character.
I'm really sorry for the interruption, ma'am.
That's okay. Okay, so Dr. Vasundhara, how did that feel, honestly?
Ma'am, honestly, a bit artificial. I still have to get used to the fact that I'm not sitting in front of a patient and a simulated patient is there. So I actually have to consider. But apart from that, yes, I missed out on some points, and the time is something that I should take care of better, is how I feel.
Yeah. And only practice will bring that. You've got a nice, gentle manner, and that's good. And you kept it, flowing, consistent. That was good. The one thing, though, you didn't ask me my name.
I'm sorry, ma'am.
That's okay. Yeah. But I think that's something we've got to remember. It's not a patient over there. You've got to identify the person, right? And the first thing you do when you make a connection with a person, try and gain the trust, the first thing you ask is, this is my name, what's yours? Yeah, that's the first basic thing. The other thing that you absolutely cannot miss when you're doing a risk assessment of suicide is past attempts, history of suicide. And with this particular question, I can play any number of patients. This girl, obviously, I think even reading between the lines, everything was okay until yesterday morning or this morning when she attempted to cut her wrists. But I would have, if I had the time, I would touch upon at least a history of depression and rule that out. But depending on the brief the actor gets, this could very well be a case of depression. It could be somebody with borderline personality disorder where cutting is a matter of routine and it's the first time that the parents have caught her doing it, but she does it on a regular basis to relieve tension and feel a kind of comfort and satisfaction that most borderline patients describe with cutting and self-harming. The other thing examination boards do is they can keep the same question, as I said, the same input as you go into the cubicle, but the brief they've given to the patient is different. And when the exam questions kind of go around, people in their heads think that, oh, I know this question. My friend did this last month or whatever. This, I know the story, etc. And they go in thinking that's going to be it. And then they get quite stumped because the story that starts unrolling is a very different story. And that can be done with every scenario. So never go into a scenario thinking, oh, I've heard about this scenario, because the scenario could have been very trickily changed with the same thing. Yeah. it's theoretically not a difficult scenario. You know, you're doing a risk assessment, you ask about the circumstances, you ask about the current intent, you ask about suicide notes preparation, time that it has been prepared for, you ask about the past history, you check for a history of depression, and then you look at, you know, how are you going to support this person, because she doesn't seem clinically depressed, but she's going through a very fragile state. She's done a suicide note. She doesn't see the light at the end of the tunnel, but given time, this is going to settle down, but she's going to have a lot of support, whether that's going to be on a private unit with constant observations or with a family member who she trusts. It can go either way, yeah? But it doesn't look like you need to start her on antidepressants straight away. You'd probably give her another thing to overdose on rather than really help her. But that was the scenario, just as an opening, right? Okay, so that's our first scenario done. Mahesh, we are okay to go into the second scenario?
We have another Dr. Rima also on the panel. I think,
okay. Okay, so Dr. Rima is going to be our next volunteer?
Yes, ma'am. Dr. Rima,
Okay.
if you can put on your video.
Right. Okay. Right, Rima, you have, everybody see case scenario 2? Yeah?
Yes, ma'am.
Yeah, okay. So, Rima, you've got a very different scenario. You have been asked to see a 20-year-old man at a police station. I'm not entirely sure that this might be in India, but you know, think about it in whichever scenario. It's an emergency situation. This person has walked into the police station stating that he needs police protection because his wife is planning to kill him with laser beams that night. He is adamant that the police check his house for the equipment and says that if forced to go home or if his family is contacted, he will kill himself. He is going to be murdered anyways, so he might as well do it himself. Take a focused history and do a mental state examination. That's the information you have, right? So you are going to have to suspend reality a bit and think that I am that 25-year-old man, right? Okay, so your time starts now. We are in roll. Yeah, okay, go ahead.
Yeah, I'm Dr. Rima.
Hello?
Can you tell me your name? I would be talking to you. Hello.
I'm Deepak. And did you say you were a doctor?
Okay. I'm the police in charge over here in the police station, and I would can I be a help to you?
You said you're a doctor.
Yeah.
Okay, why do I need a doctor? I came to the police for protection. Why is a doctor talking to me?
Can you please introduce me your name? Can I be a help to you?
I'm Deepak, and I've told the police over here that I need protection because my wife is trying to kill me. What do I need a doctor for? Do you think I'm mental?
It's not that I find you to be a mental, but as part of the assessment, I would be talking to you for a while, and if I can be a help to you, you can feel free to tell about your problems. What is it that made it to come to the police station?
Okay, I'll tell you. right? And I need police protection. I don't need an assessment. I don't need a doctor. There's nothing wrong with me. I don't know why the police have asked a doctor to talk to me. You should actually be talking to my wife. She's trying to kill me.
Okay.
And this has been building up for 1 month. For 1 month, I have been watching how she's been behaving. And she's been behaving funny. She's been behaving strangely.
Okay. So what did happen 1 month back?
1 month back, the first time I realized is that my food, she prepared lunch for me as she does, and the food was tasting funny. And when I had that food, I had very bad stomach cramps. First time I thought maybe the food was a little bad. And then I started noticing that every time she cooks instead of the maid, every time she cooks the food, I'm getting stomach cramps. She's trying to poison me. But she's getting tired. The slow poison isn't working. I have a feeling it's arsenic. You can slow poison people with arsenic. So I think she's putting arsenic in my food. But now she's got so impatient, she wants to kill me straight away. So she's having more phone calls, more texts. She's become more secretive. And now I have discovered her plan. This night, if I go back home, tomorrow the police will find my dead body and I'll be killed by laser. That is what is happening,
Tell
doctor.
me the reason. Why would she kill you?
She's possibly having an affair. That's why she wants to get rid of me. I think she's taking out some heavy
How much charges
against my name as well.
Okay.
She denies it.
So by killing you, what? Yeah. Okay. How have
Dr. Rima, we lost you in between. Maybe you have to repeat your question.
okay. Hello.
Hello? Yes?
Yeah. How your mood has been in the last 1 week?
I've been very worried. I've been very worried. I've been very angry with what is happening, and nobody seems to believe me. I have told my children, you know, they are very small anyway. What do they understand? I've told my brother. Even my parents don't believe me.
Okay. So about this thing, have you informed to any other person apart?
Yeah, I've told my family, and today I got desperate, so I came to the police.
Dr. Rima, we lost you again.
Am I audible?
Yeah, now you are.
Yeah. About these things which are disturbing, have you informed to any other person in your family apart from coming to the police station for help?
Yeah, I told my parents, I told my brother. Nobody believes me.
Okay. So what do you feel? What kind of help from police you can get?
The police should go and search my house and find the laser equipment by which she was planning to kill me. If they can find that equipment, then and then they should bring a charge against her for attempted murder.
Okay.
Blood tests, I'm sure they will find arsenic in my blood as well.
Okay.
That is all the help I need. I don't need a doctor. I don't need any treatment. I just
How
need
has been your Okay. Can you just tell me that since you are worried about all these things, do you feel that you should end your life and not live anymore and attempt a suicide? Has these thoughts come to your mind any point of time in last 1 month?
Yes, if police force me to go home, I might as well just run in front of a car. In that way, I will at least not give my wife the satisfaction of killing me. At least I would have ended my life on my own terms. So if they are going to force me to go home and say all this is nonsense, I'm going to kill myself. What else do I have? I'm going to die anyway. She's going to murder me tonight anyway. So what's the point?
Okay. Okay. Does it ever happen that when you are just doing your work and sitting idle, you hear voices of your family members trying to conspire against you?
I've heard my wife talk in the next room on her mobile.
Okay.
And it's the way she smiles, and then she won't tell me exactly who she's talking with. I can hear snippets of things that she's saying, and she says it's all innocent.
Okay. Okay. So how frequent these voices you hear talking about
Voices? I don't hear voices.
related to you talking?
My wife talking in the next room.
So whom she would be talking?
She's talking to her
phone with some other person,
talking to the people that she's planning to murder me with. She must be getting the laser equipment from somewhere.
Okay.
Doctor, do you believe me? Do you believe me?
Yeah, I try to believe you. What things are disturbing you, and what I feel is I can be a help to you.
So you will tell the police to go and search my house today and give a strict telling off to my wife?
Yeah, so for this, I need the help of your family member, and then we can definitely.
Why do you need the help of my family member? I told you.
Investigating what is going wrong.
Nobody believes me. Nobody believes me.
Yeah, I agree that nobody is believing you. But since you have come to the police station for asking help, I need to have a talk with one of the family members whom you would consent, and then I can proceed with the investigation.
We have 1 minute more.
So, doctor, you don't believe me?
It is not about believing you. It is for your betterment. I would request you that you just consent in this.
You're all in league with my wife. You're planning with her. I'm sure she's already got contacts in the police, and this is all a conspiracy to frame me mad.
Okay. To my knowledge, what I've understood is like since last 1 month, you feel that your wife is trying to poison you by mixing something, and the food is tasting somewhat weird in taste. And you also feel that your wife might have an extramarital affair because of which she plans to kill you. And
yes.
the way she might kill you is using the laser beam technology. And
yes.
You have an active suicidal thought that if there is no one to help you, you might end your life also. Am I correct?
Yes, you're correct on that ground, but you keep on saying I believe. It's not what I believe, it's the fact.
Okay. One thing what I would like to assure you is that since you have come to for asking help, I can be a help to you, and I would help you in investigating further. But you need to consent us.
I want you to investigate my wife.
Time up.
Yeah.
Right, out of character. Okay, so Dr. Reema, how did that feel? Very brave again. Thank you. Okay.
I felt was I made my introduction as I am a doctor, so that part went a bit out of the normal scenario. And what difficulty I felt was this 10 minutes of time assessing the history and doing a brief mental state examination. I felt that it was a bit difficult for me to gather information related to the history and brief MSc.
Yeah. Time is very tight. So the tips over there are, okay, first of all, the good things is that you didn't lose your cool. The patient was difficult, the patient was hostile, but you kept up, just as Vasundhara did, even if it's an uncooperative patient. Keeping that professional facade is very important, right? What you might have saved time on is that you didn't have to formulate any management with this patient. That just went into more conflict. I'm going to contact your family members. We are going to, try and find out what's happening. Your brief over here is history and mental state. Just get a brief of what is happening. You do not, if they've not asked you for management, don't touch management at all. Yeah. So you could, I like the fact that you summarized, you got that bit from the slide. So as long as you just ask the patient's story, you summarize the story in the form of short history and mental state examination, and you get back to the examiner that this is the history that I've elicited. You explored for auditory hallucinations. So kind of major things, somebody appearing delusional, at least one major thing that you've got out. Thought alienation is a anyway, so I don't think an examiner should be so tough that you've not talked about, there can be, doing a psychosis MSc takes an hour, we know that. So, but at least you've talked about auditory hallucinations, that's basic. You've got the gist of the delusional story, that's absolutely fine. You can expect a patient in this scenario to be hostile, and it's just to be prepared for it. So just to keep on saying, I want to hear your side of the story. If the patient says that, do you believe me? Or you're not believing me. If they throw it in as a brief to see how the candidate reacts, how they manage that situation, then you could say something along the lines of, this is the first time that I'm meeting you. I want to know your entire story. I want to know the details first before I can make up my mind. So tell me more. That way you get more psychopathology without colluding either way, or colluding or denying. If you say that, I don't know your entire story, I want to know more, then you can, get over that point. But well tried out, good effort, and you got the major points. So I would give it a definite pass, so good going. Good one on that one. Okay. Mahesh, I'm a bit mindful of the time as well. Are we okay to just carry on?
Yes, ma'am. Yes.
Okay. So another 10 minutes on this last scenario. And is it Alka who's going to be our last candidate?
Dr. Alka, can you show up your video? Dr. Alka? Okay. Dr. Vasundhara, can you take up the next case?
Yes, sir.
Yeah.
Okay. So Vasundhara, let me, gosh, it's showing me all kinds of sharing options over here. Actually, Sriram, can you just share the slide on case scenario 3 for us?
Yeah, I'll do that.
Yeah, just case scenario 3. Thank you. Okay, Vasundhara, so it only gets better. You've been asked to examine an elderly man in accident and emergency. He was picked up by members of the public because he was wandering around disheveled and smelly, brought to hospital. In A&E, he has remained agitated, sometimes cowering in the corner of the room, says that he can see snakes crawling around him, do a relevant mental state examination. So you just try and get as many symptoms from this person as possible. Yeah? Okay. Shall we stop screen sharing? Yeah, there's Vasundhara and me visible then. Okay.
Hello, I'm Dr. Vasundhara. I'm one of the trainee psychiatrists over
Snakes.
here.
Doctor, there are snakes all around the wall, all around the room. Can you see the snakes? Can you see the snakes?
Okay, where do you think the snakes are?
They're all around. They're all behind you. They're all behind you. Doctor, you should move. You should move. They're here.
All right.
I see the snakes.
I understand. I'm unable to see the snakes, miss. I'm sure they will not harm. I'm sorry. I'm unable to see them at the moment. I'm sure they won't harm you. You're in a safe zone right now.
Do you think so?
Yes. Can you tell me your name?
Amit.
Amit. And how old are you, Mr. Amit?
60? 65?
Okay. Can you tell me where you're from?
I'm from nearby.
I'm sure you're in a safe. I'm sure you're in a safe zone, Mr. Amit. All right. This is going to be a safe zone.
Where am I?
You're currently in a hospital.
I'm in a hospital. Who brought me here?
You brought by the local people?
By the local people?
Yes.
Why did they bring me to hospital?
They told me that they found you outside and you seemed very stressed.
Who are you?
I'm Dr. Vasundhara. I'm one of the trainee psychiatrists at this hospital.
You're a doctor?
Yes.
Can
I ask you some questions? I understand.
What questions?
Okay. You said you're from nearby. Can you tell me, do you remember what happened recently? How did you land up on the street? No.
I think I left home. I left home to go to the shop. I got lost.
I understand. What did you want from the shop?
I wanted a drink.
Okay, I understand. And how far is the shop from your house?
It's just nearby. It's round the corner.
Okay. Were you able to get to the shop? Okay.
Where am I?
You're in the hospital right now.
There are snakes. There are snakes.
I understand. Please be assured that you're in a safe zone right now. Okay. Can you tell me who all live with you at your house?
My wife.
Okay. Did you inform her before you went to the store today?
Can't remember.
Okay. All right. And
I don't think so. She won't let me take a drink. Okay. She says I drink too much.
Okay. Do you usually drink on a daily basis?
I can't help it. If I don't drink, I get these shakes. Snakes. I can see those snakes.
Okay. I understand. You're in a safe zone right now, Mr. Amit. I will make sure that the snakes don't harm you. All right? Can I ask you some more questions?
Okay.
Can you tell me what time of the day it is? Is it morning for you? Is it evening for you?
It's night. The lights are on. It must be night.
And can you tell me what day of the week it is?
Sunday.
Okay. And can you tell me what month it is or what year it is right now?
December 2016.
Mm-hmm. Can you tell me what object you're looking at right now?
Pencil.
Right. And what do you do with this?
You write?
Okay. Okay. That's good. Okay. And do you realize now where you are?
Safe place.
Right. Yes. Your other
Who
hospital.
are you
right
again?
now.
Who are you?
I'm Dr. Vasundhara. I am a DNB trainee at this hospital.
Okay.
Right.
Okay.
Can I ask you some more questions about your alcohol?
Yeah.
Can you tell me how much you usually take regularly? How much alcohol do you consume?
I just keep drinking. If I don't drink, I shake.
Mm-hmm.
I don't
I
want
understand
to,
that
but
must
I
be.
can't help it.
I understand that must be very distressing for you. And how long have you been experiencing this shaking for?
Last 1 year, but it's getting worse.
Mm-hmm. And was that at that time that you realized that you would shake if you wouldn't drink?
Yeah.
Okay. When you say that you don't have an upper limit for your alcohol, can you tell me what happens? Okay, I understand you feel very distressed right now. How long have you been seeing these snakes for?
Just now.
Okay. And can you describe these snakes to me?
Just green, yellow, disgusting. And they're frightening me.
And where are they at the moment?
They're all around us.
Okay.
Are you sure you can't see them?
I'm afraid I can't see them at the moment, but I will help you with what because you seem distressed and you can see them.
I need a drink.
Okay.
I need a drink.
We could talk about that a little more too. Just to clarify, do you also feel these snakes on you, or are you only able to see them?
I can just see them.
Okay, and are they as clearly as you can see me right now? Okay. What do you think these snakes may do?
I don't know. They want to bite me?
Have you ever seen snakes before this while you were drinking?
Can't remember.
This is the first time, from what you understand?
Yeah.
Okay. Okay, I understand. How long ago was your last drink?
Sunday.
Okay, Sunday, right. So that's today then? How many hours ago was your last drink for?
What day is it today?
Sunday.
No, I didn't have a drink today.
You didn't? Did you have one yesterday night?
I don't know. The days merge into each other.
Okay. Do you usually drink in the mornings or the nights?
Throughout the day. As long as
I understand. Okay. So I'm going to tell you that this could be a possible reaction from your drinking. Okay, so when a person suddenly stops drinking, they may see or hear things that other people are unable to see or hear. So as a result of which they may feel extremely scared. So I understand
1 minute
that you
more.
I understand that this must be extremely distressing for you. Is it possible for you to give me some contact information so I can contact your wife?
I think I have my mobile in my pocket.
That's wonderful. So we could just contact her and she would come here and then we could discuss what to do on further. Is that going to be okay?
Yeah, yeah.
That's wonderful, sir. Thank you for speaking to me. You've been very brave and I'm sure we'll be able to be able to treat you and manage this successfully, yes?
Thank you.
All right. Thank you.
Okay, I can stop shaking now?
Yes, ma'am.
Okay, so how did that feel, Vasundhara?
Much better than the last one, ma'am.
Yeah, see, the practice helps.
Yes,
Yeah,
sir.
yeah. Okay, so what I'm seeing over here with all the scenarios and even with Rima is that it's very difficult not to give a management plan to the patient. You know,
Yes, ma'am.
you are very helpful people. You love helping your patients, and it always feels comfortable to have that rounded off, this is how we are going to help you. But if the scenario doesn't ask for a management plan, you've got only 15 minutes. Of course, today we've just done a tight practice. We've done it for 10 minutes. You do have another 5 extra minutes in your exam, but it's still very tight. So don't do anything that the scenario doesn't ask you to do. What you could have done, you got the main points that, this is an alcohol problem, you got the hallucinations. As long as you've detected it's a visual hallucination, fine. You don't need to go into too much detail over there. I would have spent that time on a bit more of attention tests in alcohol, whether it's counting months backward or saying the days of the week backward, serial sevens, spelling world backward. Naming is not really something very distinctively that will, you don't have to do a full MMSC, but, focus on attention, concentration, short memory. So this person is obviously not orientated. That was very obvious. Doesn't remember his own address, is unclear about his age, but to show that he cannot make new memories, giving him something to remember. The address test is a very standard test. If you look into various textbooks, what tests you should do for alcohol or for delirium or for cognitive tests will vary. For a cask scenario, you can take the most selected tests that you can carry out. So think about it more in chunks of functions: attention, concentration, short-term memory. That's what you want to do for alcohol. So you could have done, the attention tests. You could have given them an address to remember. So an address with at least 5 points. After 5 minutes or so, ask the patient back to repeat the address and forgotten, right? A bit of maths, a bit of other language tests. Of course, if you had 1 hour with this patient, you could do a full cognitive battery, but that's not the point. But you did get the main thing. What you need to do over here is to, yes, you've identified visual hallucinations, then you launch into the majority to get the cognitive tests, and you don't have to summarize to the patient. If you can kind of take it off in your mind that, right, I've done these tests. And if you're doing it very clearly, you're doing attention, concentration, memory. If you're doing it in a sequence, your examiner will get it, that, you've got the essence of the station.
Yes,
right? Okay, so I've just got one last slide to share on other tips. Shriram, if you share that last 2 slides with me, please, and then I'll finish my talking and open up for questions.
Sure.
Yeah. Okay, so just to end up, make an impression. First impressions do count. Form and content are both important. So for example, let's say you're talking to a patient about side effects of lithium. You might get a great form. You go in, introduce yourself, make the patient comfortable, ask them what they already know, whether they have any specific questions. You give them information in bite-sized chunks. At the end, you check with them how much they've understood, summarized. Great form. But it might be that your content is very, very thin. On the other hand, you can have great content. You can go and sit the patient in front of you and go, right, I'm going to tell you about the side effects of lithium, and then lecture them as you would lecture a student. Both approaches have flaws. So it's to bring both of them together. Tips: practice, practice, practice. Make groups of 3 within your friends, one of them being a patient, one of them being an examinee, and one of them being the observer who can give you feedback. And when you're observing, it's interesting to see how much more you will pick up as what should have been done. When you're in the position yourself, then the exact things go out of your head. So be constructively critical of each other. Video yourself. That's very easy nowadays. Everybody has smartphones, and be honest in your own evaluation about how you come across, whether you're coming across as confident, warm, or do you come across as arrogant, not listening. Get rid of unpleasant mannerisms. It can be very annoying for an examiner to go through an entire 15 minutes hearing the same phrase. And there are things that we are not aware of, in starting every sentence with basically, or starting every sentence with in fact, or when showing empathy to a patient, keeping on saying, I'm sure I can help you. I'm sure we can do something for you, and saying that a dozen times. If you're going to be empathic, try and find different phrases, different ways of saying it. You don't even have to say it. Sometimes just a gentle manner, nod of your head might do. It is a drama, but you've got to be as natural as possible. And it's a bit of that practice, doing it in a way of suspending reality and believing that the person in front of you is a real patient, and you do as you would want to be treated yourself. So that's all from my end. I'm happy for questions if people are not rushed for time. Good luck. Okay. Mahesh, any comments, or shall I go into the chat?
Dr. Nandini, I think you could take any questions if there's any there.
Okay.
I was also looking at the chat.
Yeah. So I'm looking for questions. There are lots of comments I can see. Okay, somebody said tough client on both scenarios, but I'd rather I be tough on you than you face that for the first time in your exam. That's why I'm here. Okay. Well, nice, very, very nice compliments over there. Thank you all very much. Okay. OSCE series. There aren't any OSCE series open on YouTube. The Royal College and PLAB are very, I would say, very possessive about the scenarios that they have. So they're not going to put it up on YouTube. What look for is Image Gap has some training material, right? So it's actually pitched at a completely different level. But it just gives you that tips of, how to approach, how to come up, and trying to replicate that same kind of demeanor when you're doing a scenario with a patient. That might be helpful. So go across to YouTube and look at as many simulated psychiatry, image gap interview YouTubes, and practice amongst yourselves. Practice makes perfect. You'll be fine. Yeah. Oh, somebody's doing DNB and MRC Psych. Yeah, I'm sure you will find that useful. You'll have to be prepared for everything. Somebody's asked, what are the other probable simulated cases? Oh, there's an indefinite number. As I said, for each of those 3 scenarios, you could write, innumerable number of briefs. It could be anything. So what our examiners do actually is that they write a lot of histories, they write a lot of briefs for the actors. So you could, what you could do is, you do real case workups, right? You have real histories. Oh, Mahesh is mute. Mahesh, you're mute. Can't hear you. Are you okay?
I'm okay.
Yeah, okay. So what you could do is you could take real histories and then play that patient for your friends. Somebody has said in scenario 2, can we tell the patient that we need to admit you to check the levels of arsenic and give treatment for the same? Oh, that's interesting. In fact, if we ever went on to management, I would rather say that why don't we admit you to make sure that you're safe and we can address what your concerns are. I wouldn't make it so specific that we are going to test your levels of arsenic, because that's going to be outright lying. You're not going to set blood for arsenic levels, but you can certainly say that we will admit you to hospital to make sure that you are safe and to investigate the situation a bit more, which is not lying in a way. Okay. That's all I have to say, Mahesh. I don't think there's any more questions coming through.
Thank you, Dr. Nandini. I must admit that after a long time, I had got to listen to something as good as this. And you're a very tough, client for any examiner to actually deal with, or any of my students to actually evaluate you. And you did it so well, and it didn't look like an assignment case at all. You were so realistic, and I must admit that you're very good at acting. And you are hands-on and very tough for any of the examining students today. It would have been very tough.
If they've dealt with me today, they'll deal with anybody.
Yes. So
yes.
That will also help them anticipate problems. They will know that there could be a lot of resistance for coming up with history, clarifications, and not so cooperative patients is something that they will learn to deal with. I think this is a good session overall for all of them. This recording is there on YouTube. I'm sure a lot of people are going to visit that and relook at what happened, what went wrong, what is the better way of questioning, and looking at the most appropriate way of framing a question, because the examiners are going to look at how well you framed your questions and did they actually pick up a clue from what you're saying. Exactly. I was looking at, as a client, you was giving them so many clues, but, all the 3 scenarios, they didn't pick it up because they had a preset agenda that they had to target and get so many history from you. So they get, fixed on that. But they could have actually spent 1 or 2 sentences trying to pick up from what you had said. So to pick on the lead is very important. But I think it's a good training and learning exercise for all of us. Thank you for taking your time out and spending this 1 hour plus with the students today. We had 100 plus people on the Zoom itself, and we had another 30 plus on YouTube. So they'll get a lot of time to go back and review. So subsequent to whatever we have seen, there are more than 150, 200 people going and reviewing and seeing. So it'll definitely serve as good teaching and learning material for the students. And thanks once again from all of us for agreeing to be with us. And I really had a surprise volunteering from you to take this sort of class from them. And I'll really relish this. Thank you so much, Dr. Nandini.
Any questions, please forward to me. I'll be happy to answer them separately.
Yeah. Thank you all students for attending and making this a grand success for us. Thank you so much.
Okay. Thank you, everybody. Bye.
Thanks, Sriram.
Thanks.
Bye.